On behalf of Dr. Luxon and the Department of Medicine, and Dr. Joseph Timpone, who's the Director of Clinical Research for the Division of Infectious Diseases, it truly gives me utmost pleasure and privilege to introduce our Grand Round speaker, who's one of my heroes, Dr. Robin Avery. Dr. Robin Avery went to actually did her undergraduate in Harvard, where she graduated summa cum laude. She then attended the medical school there at Harvard and did her residency and fellowship at Mass General. Her fellowship, of course, was in infectious diseases. Cleveland Clinic then had the privilege of hiring Dr. Avery, and she rose among the ranks to then lead the transplant clinic there at Cleveland Clinic. In 2012, Hopkins then, I like to use the word, poached her away from Cleveland Clinic, and she has been at Hopkins since 2012. She is a critical member of anything related to transplant. As I look through her CV, there are lots of organizations that I didn't even know exist that she's a critical part of. I just name a few of it. She served as the head of AST, some of the AST guidelines, but her special areas of interest are in viral infections, novel therapies for CMV, infections in incompatible kidney transplant recipients, and strategies for safer living after transplant. In 2017, she was named Best Consulting Physician at Hopkins. In 2020, when the pandemic started, she turned her interest slightly, but combined her love for transplant, serving the very vulnerable immunocompromised patients who were affected with COVID-19, and much of her research has been focused on that. She has innumerous publications, and as I said, for the American Society for Transplant, she has served many leadership roles. But the reason I consider her one of my heroes is that there's never been a time that Joe Timpone and I have reached out to her with a question, a concern about a transplant patient, that she stops and gives us her full attention, no matter how busy she is. And she does it with such grace and such humility that we, I'm old right now, but I always think in the years that are left behind for me, I want to emulate and be like her. And with this, I want to turn over to you, Dr. Avery, but to the rest of the group, about Robin Avery, to the rest of the group, this is our week. We have managed to celebrate the Research Week despite the virtual nature of it. As a division, I want to extend my warmest appreciation to everybody who made it a success. A special thanks to all the interns, residents, students, and faculty that participated. And with this, Dr. Robin Avery, I'm going to turn it over to you. Thank you.
Thank you so much, Dr. Kumar. I have to say you brought tears to my eyes. I am really, truly honored and humbled to be here with you today. You have a fantastic Department of Medicine, an extraordinary Division of Infectious Disease, and I have to also congratulate all of you for any of you involved in transplant care, because during the pandemic, when many, many other centers dropped their transplant volumes, Georgetown alone stood with continued high transplant volume and high quality transplant care, and really are a model for all of us. So I'd like to thank Dr. Kumar, Dr. Timpone, Dr. Gross, and the planning committee. It's really an honor to be here as part of your research week and to share with you some of the recent work that we've done in protecting our most vulnerable transplant recipients from infections. Today, I'd like to touch on resistant refractory CMV, incompatible kidney transplant recipients, neutropenia, and COVID-19. So my disclosures are shown. I am an investigator on a number of pharmaceutical-funded studies, but I don't receive any personal financial remuneration from any pharmaceutical entity. I will be mentioning some off-label and EUA uses and investigational agents as listed here. I will be talking about our neutropenia study, which was an investigator-initiated study funded by the Merck MISP program, and the Maribavir phase 2 and phase 3 trials were multi-center trials funded by Takeda Shire. So I'd like to say a word about gratitude to our teachers. Just as those of you in training I know will be grateful all your life to Dr. Kumar, Dr. Timpone, and the other outstanding educators that you have learned clinical medicine from. I also remember my teachers over the years with great gratitude and humility. In particular, Dr. Bob Rubin, one of my main mentors and really one of the founders of Transplant Infectious Disease, is somebody who I always refer to in every talk, and in fact think about him when I have many complex patient scenarios to look at. And here's Bob Rubin back when he was very clinically active at Mass General. A number of the concepts we think of today as foundational in transplant infectious disease derive from some of Bob's ideas back in the 1980s and still hold true with some modifications today. I'll refer several times in this lecture to the net state of immunosuppression, which is the concept that for a given patient, it's not only the drugs and doses of immunosuppressive meds they're receiving, but many, many other factors, including age, comorbidities, metabolic abnormalities, organ dysfunction, neutropenia, hypogammaglobulinemia, breaches in skin and mucosal barriers, non-anatomic fluid collections, and things of that nature, all of which add up to a particular individual's immunosuppressive state at any given time. There's also Bob Rubin's 3-part timetable of infections after transplant, the first month, months 2 through 6, and then after that, where the first month are primarily post-surgical infections or donor-derived infections. And then the second time period is largely opportunistic infections. And then in a late time period, patients are divided into several different risk groups depending upon what degree of rejection they've had and which of the long-term viruses they still carry. Then there's the idea of the transplant patient as a sentinel chicken, the concept that no matter what's transmitting in the community, our transplant recipients are probably going to get it earlier, more severely, and sometimes in a more protracted fashion than others. And that's true, for example, of norovirus. Some of our patients develop a severe chronic norovirus infection. That's actually one of my main interests, although I won't talk about it today. And again, Bob Rubin's idea that if you know the net state of immunosuppression, the time post-transplant, and the environmental exposures of the patient, for example, some of our patients work in farming or construction or areas where they're exposed to fungal organisms, et cetera, you can deduce from that what infection the patient is likely to have at any point in time. And always the subtext of everything that Bob Rubin did was to go the extra mile to protect the most vulnerable. And for the 30-some years that I've been in the field, I have tried to do that. So let's start with CMV. You can see why it's called cytomegalovirus here by the inclusion body in the cell here in the lung. And despite all of our advances in prophylaxis and treatment, CMV, viremia, and end-organ disease still occur after both solid organ and hematopoietic stem cell transplantation. We've not completely eliminated CMV. The existing drugs, as you know, have toxicities which are sometimes severe, particularly again, cyclovir and valganciclovir cause neutropenia, which can lead to other infections. Foscarnet is known for nephrotoxicity, cidofovir for nephrotoxicity and uveitis. And then we have a number of CMV syndromes that don't respond to standard therapies. Some of them are genotypically resistant with mutations in the UL97 or the UL54 gene. But then there's this very interesting entity of refractory CMV, which behaves just like resistant CMV, but without a detectable mutation. And those of you who do transplant infectious disease, you know that some of these are some of the most complex and challenging patients that we encounter. So on the horizon, first of all, we had the approval of the Termavir back in 2017 for bone marrow transplant prophylaxis. Its off-label use for treatment of resistant refractory CMV is still a question. And we have Maribavir, which is actually being actively developed for resistant refractory CMV therapy. It is investigational still, but recently a phase 3 trial of resistant refractory CMV was completed that I will tell you about. It is a novel drug with a new mechanism of action that's not like any of the other CMV drugs. It's a benzimidazole, and it works by inhibiting the UL97 viral protein kinase. It inhibits encapsulation and nuclear egress of viral particles. So unlike other CMV agents, it doesn't directly inhibit the CMV DNA polymerase, and therefore it's potentially active against CMV strains resistant to other agents. So back a few years ago, there was a phase 2 study of Maribavir in resistant refractory CMV. And I should preface this by saying that this drug almost disappeared from development because the initial prophylaxis trials in liver transplant and bone marrow transplant simply didn't work. Unfortunately, it's now thought that those trials probably used a dose of Maribavir that was 4 times too low. But it was salvaged because of a compassionate use program back in 2008, where it actually cured some patients with truly refractory CMV. So this phase 2 study was one of the results. This was a dose-ranging 3-arm study, and the primary endpoint was viremia clearance at 6 weeks, but you were allowed to continue Maribavir up to 24 weeks. We'll come back to that in a moment. And actually, there was about a 2/3 response overall, which when you consider these were patients in deep salvage for CMV, they were in trouble with multiple recurrences, that's actually quite a remarkable response. There was, however, a 35% recurrence rate. We'll get back to that again, too. And again, many of these patients are going to be subject to recurrences because it's the nature of viruses in the herpes virus family to try again and again to come back. Whether it's HSV, VZV, CMV, these viruses will try to recur, but most of the time the immune system prevents them from getting very far. In terms of side effects of Maribavir, the main one is dysgeusia, a bad taste which can persist for a couple hours after the dose, but most of the time is not severe enough to require discontinuation. Nausea also occurs in about 1/3. However, there's no myelotoxicity, no nephrotoxicity, so it lacks the major toxicities of the other CMV drugs. So there are now 2 phase 3 Maribavir trials. The first one has recently been completed and one abstract has been presented. It was a study 303, which is a resistant refractory CMV trial. It's a 2-to-1 randomized open label trial of Maribavir versus investigator-assigned therapy. What do I mean by that? I will tell you in a moment. It's a rather unique trial design. And then there's another parallel trial that's still enrolling, about 3/4 enrolled now, which is a double-blind randomized trial of Maribavir versus Valganciclovir for preemptive therapy of uncomplicated CMV viremia in stem cell transplants, who of course are prone to neutropenia, so that may turn out to be a useful way to develop this drug. So at this point, I'd like to remember, sadly, but with great honor, our colleague, mentor, and friend, Dr. Francisco Marty, who tragically passed away last month, was an avid photographer and was photographing a waterfall and unfortunately died in an accident. But Francisco had a great deal to do with the development of Maribavir, including back in 2008 when the drug development was almost scuttled. He also had a lot to do with the study design I'm going to tell you about, making this study flexible enough to accommodate all kinds of patients with different needs and to really put the top priority as the best care of the patient, even within the context of the study. So basically, this was a study, again, as I mentioned, Maribavir versus investigator-assigned antiviral therapy. What that meant is that 2/3 of the patients were randomized to Maribavir, 1/3 were randomized to whatever the physician thought they should be on. It could be ganciclovir, valganciclovir, foscarnet, or cidofovir, the standard drugs. And that took account of these patients having varied treatment histories, different toxicity histories, and so forth, and giving you the flexibility to choose what you felt was best for the patient. So the primary endpoint was clearing CMV viremia at the end of treatment of 8 weeks. And then the key secondary endpoint was keeping that going, clearing the CMV and clearing CMV symptoms after treatment and out to 16 weeks. And then there were a variety of other secondary endpoints, as you see here: recurrences, all-cause mortality, mutations, safety, et cetera, and pharmacokinetics. And the key, this is again, Francisco Marty presented this at the TCT meeting, so although it's not published yet, I can tell you these results. The key endpoint findings were the primary endpoint. Maribavir achieved this significantly more often than investigator-associated therapy, and that was clearance of CMV viremia at 8 weeks occurred in 55.7% of the Maribavir group, 23.9% of the investigator-assigned group. And then the key secondary endpoint, there was also a significant difference between Maribavir and IAT, 18.7 versus 10.3%, but you'll notice that both of those numbers are relatively low, meaning that a number of patients did have recurrences when they were off therapy. Now, I don't think this necessarily means that the drug doesn't work, but keep in mind that in the phase 2 trial, we were allowed to keep treating patients out to 24 weeks with Maribavir. So it may mean that some of these patients need to be treated again or may benefit from a long course of secondary prophylaxis after they've first controlled their CMV viremia, rather than simply coming off therapy altogether at that point. So it may actually speak more to how we use the drug in the future if it does get FDA approved. In terms of side effects, as expected, dysgeusia was more common with Maribavir, neutropenia was more common with Valganciclovir, acute kidney injury was more common with foscarnet. And so the overall conclusion was that Maribavir was superior to investigator-assigned for CMV viremia clearance at 8 weeks in transplant recipients with resistant or refractory CMV infection, and there was a lower incidence of treatment-limiting toxicities with Maribavir. So we will see if these results are also echoed in the uncomplicated CMV viremia study going on, and we hope that this will lead to an expansion of our armamentarium for treating resistant CMV. I'll turn now to a different vulnerable group, incompatible living donor kidney transplant recipients. And for this and the next few studies, I'd like to acknowledge the collaboration of our epidemiology and transplantation, or ERGOT, led by Dori Sega, and in this particular study, the analyst Jennifer Motter, who worked closely with the data with me. So why would we do incompatible living donor kidney transplants? So each year, thousands of kidney transplant candidates have a donor who comes forth and who is healthy and willing, but who is HLA incompatible. So they have several options at that point. They can stay on the deceased donor wait list, but may wait 8 years or more and suffer morbidity during that time. Or they may enter the paired kidney donation program, which is excellent if you do find a donor through that program, but not everyone does. If you are unable to find a donor in the paired donation program, then there are ways that you can undergo desensitization to undergo an HLA or ABO incompatible transplant. And there's actually a paper by Bob Montgomery and Dori Segev from some years ago in New England Journal that shows that there's an overall survival benefit for these patients to getting the incompatible transplant. However, those of us who do the ID consults on the floors, as you do, know that not all of these patients do well in terms of infections. And in fact, we noted for some years that there's a small subgroup of these patients that has really severe recurrent infections, just seem to be relentless in terms of one admission after another, but that was not true of this whole incompatible group. And we wondered why, and we sought to try to find what some of those risk factors were. So we collected data on close to 500 living donor kidney recipients who received transplants at Hopkins over a 5-year period. 215 were incompatible and 260 were compatible transplants. And we defined incompatible as anyone who required perioperative desensitization, which at Hopkins is usually plasmapheresis plus low-dose IVIG. Some other centers use high-dose IVIG without pheresis. And then also occasionally other anti-B-cell agents or agents that affect the B-cell compartment, including rituximab, bortezomib, eculizumab, C1 esterase inhibitor, or splenectomy. And we categorize these into 3 intensity categories. low was 1 to 4 plasmaphereses, moderate intensity was 5 to 9, and then high intensity was getting 10 or more plasmaphereses or any use of the other agents mentioned here. And so this shows you the time to first infection within the first year post-transplant by intensity of desensitization. You can see the top curve here is high, and then moderate, then low, and then none in terms of the intensity of desensitization. And for total infections and for most of the specific infections we look for, it actually fell out along these lines. This shows you the particular infections after transplant. The blue is incompatible, the orange is compatible. And again, for most of these, the incidence was significantly higher for the incompatible transplant patients, including urinary tract infections, opportunistic infections, bloodstream infections, pneumonias, C. diff, diarrhea, surgical site infections, and invasive fungal infections. We also tried to look at the adverse consequences of developing infections. So those who developed infections, as you would expect, had more hospital days than those who did not. We were actually only collecting serious infections. We were not counting asymptomatic bacteriuria or outpatient sinusitis. And those with 4 or more infections actually had a 3.6-fold increase in their rate of hospital days. And those with 4 or more infections also had other consequences in that they had a 4-fold higher risk of death-censored graft failure. So in other words, if you sort of keep battering your kidney with all these infections, eventually either the toxicities of the drugs or the infections themselves or rejection that can go hand in hand with infection may take its toll. And then again, as we had observed clinically initially, there was a small ultra-high risk group that had as many as 7 to 9 infections or even 10 or more infections during their first post-transplant year. And these groups were basically living in the hospital, or almost, 106 and 117 hospital days respectively. And many of these had undergone high-intensity desensitization. However, of the high-intensity desensitization group, only 15% fell into this ultra-high-risk category, and the others were actually doing relatively well compared to that. So we're not sure why of that. We're still working to understand who's in this high-risk group. Can we predict it antecedently, and can we build in additional protections for those patients? So conclusion, these ILDKT recipients are at increased risk for many post-transplant infections compared with compatible recipients. High intensity of desensitization identifies a group that's at even higher risk than other incompatible patients. And having 4 or more infections in the first year is associated with adverse outcomes of increased hospital days and increased risk of death-censored graft failure. So let's move to another type of vulnerability after organ transplant, those who become neutropenic. And again, this is something universal after bone marrow transplant, but is not universal or really shouldn't be universal or that frequent after solid organ transplant, except for the medications that we give these patients. So as you know, at this point, Valganciclovir is the only currently approved oral agent for CMV prophylaxis in solid organ transplant. Letermovir is approved for bone marrow transplant prophylaxis. However, neutropenia is a common issue during Valganciclovir or ganciclovir prophylaxis and treatment, and neutropenia, of course, can lead to secondary bacterial and fungal infections as well as readmissions for neutropenic fever. Furthermore, if a patient is on a 3-month or a 6-month course of Valganciclovir prophylaxis after their transplant, they develop neutropenia, it gets stopped, so it can result in truncated prophylaxis and hence increased risk for CMV reactivation. And this may be compounded by other medications that cause leukopenia and neutropenia, such as the almost universal mycophenolate mofetil. So again, with thanks to Jennifer Motter, the analyst, and to the ERGOT group here, this is an abstract at this year's ATC that we're presenting on preliminary results of our neutropenia study. So data were collected on, this is actually a larger group, over 1,000 kidney recipients, because we included deceased donor recipients as well as the living donor recipients in this one. It turned out that 36.5% at some point in time developed neutropenia, which we defined as an absolute neutrophil count of less than 1,000, and we called them the neutropenic group. Whereas 63.5% never developed neutropenia, we called them the non-neutropenic group. And we collected a variety of data, including infections out to 3 years post-transplant, and again, mild outpatient infections were excluded. And we used multivariable Poisson regression to evaluate association between neutropenia and the risk of infections. So as you'd expect, the most common infection were urinary tract infections, but also CMV, pulmonary, and bloodstream infections, and all of these were more common in the neutropenic group. In the neutropenic group, 34% had CMV DNA emia at some point in time versus only 8.4% in the non-neutropenic group. And this makes sense because CMV itself can cause neutropenia, but furthermore, our most common therapies, ganciclovir and valganciclovir, get started for CMV, and those can cause neutropenia. Neutropenic fever requiring admission occurred in 3.6%. And as we mentioned, bloodstream infections were significantly more common in the neutropenic group, as you would expect. Neutropenic patients were more likely to have the CMV serostatus of donor positive, recipient negative, which, as you know, is high risk because the patient has no antecedent CMV immunity and then gets a load of virus from the donor. So traditionally, D+R- patients have had the highest viral loads, the most recurrences, the highest risk for resistance, and the highest risk of end organ disease. And in this case, also a higher risk of neutropenia. And when we looked at total infections, not just CMV, there was a 1.71-fold increase in the number of infection cases for neutropenic recipients compared with non-neutropenic recipients. So we concluded from this, developing neutropenia at any time post-transplant, no matter whether it's a short or long duration, that identifies a group with an increased incidence of infections compared to patients who have never developed neutropenia. But causality is complex because infections may cause or contribute to neutropenia as well as resulting from it. So it's really sort of a bi-directional relationship. We would like to do further studies to design strategies for preventing post-transplant neutropenia and associated infections, which could eventually perhaps be stratifying patients to use different drugs. If letermovir, there's a current letermovir study right now for a randomized trial versus valganciclovir for kidney prophylaxis. If that trial shows benefit, then it's possible in the future that we'll have other options for prophylaxis as well. And we also need more information on the dosing and timing of valganciclovir with respect to mycophenolate and other drugs that can lower white count as well, in order to know how to use these drugs optimally and protect our patients. And finally, on to COVID-19, which I know you've all been living and doing an immensely tremendous job on this past year. So we have worked on COVID-19 in a number of ways in our group, and I'll just single out a couple of studies that may be of interest to you. So first of all, we have at Hopkins this CROWN Registry, which is a large database which is available to investigators upon application. And we actually asked for permission to analyze the data on SOT versus non-solid organ transplant patients in this registry. And I'm indebted to Teresa Po-Yu Chang, who was the main analyst on this study. So we actually did this back in August. At that time, there were a few studies that had directly compared SOT and non-SOT COVID outcomes. There were quite a few single center case series which had reported mortalities of 20, 25% or even higher early in the pandemic. We were perhaps fortunate for reasons that we don't fully understand, but our inpatient mortality for SOT patients with COVID has remained between 5 and 6%. But in any event, we elected to take advantage of the CROWN Registry to look at outcomes for SOT and non-SOT patients. And again, it's based on a precision medicine analytics platform, which includes a whole variety of patient-level data, as you see listed here. So at that time, which was in August, we had 45 solid organ transplant recipients test positive. Now we have over 450, but that's what we had at that time. And we compared them to 2,427 non-SOT patients. I'm sorry, this is inpatients who were admitted with COVID-19 to our healthcare system. So actually, we don't have 460 inpatients, we have 460 total positive patients now. So anyway, back to the study, we evaluated hospital length of stay and inpatient mortality using competing risk regression. And we particularly were interested in comparing WHO COVID severity scale over time. So using trajectories, using mixed effects ordinal logistic regression, and adjusting for severity at admission. So the two groups had comparable age, sex, and race, but the solid organ transplant recipients were more likely to have a number of comorbidities, including diabetes, hypertension, HIV, and peripheral vascular disease. However, despite that, we found no statistically significant differences between SOT and non-SOT patients in terms of their maximum illness severity score, their length of stay, or mortality. Although the severity score on admission was slightly lower for the organ transplant patients than for the others. The median duration on oxygen therapy was 4.9 days for SOT and 5.9 days for non-SOT, and this was not a significant difference. However, the nadir absolute lymphocyte count was lower in solid organ transplant patients. And again, as you know, a low lymphocyte count can be a marker for poorer outcome. The peak C-reactive protein was also lower in SOT. And so despite this higher risk profile, it turns out SOT recipients actually had a faster decline in disease severity over time. In other words, their WHO scores got better more rapidly compared with non-SOT patients. I should also mention at this point that, as many centers do, our immunosuppression management for these patients was to hold mycophenolate in the acute phase to allow the immune system to gain the upper hand against COVID, but to maintain prednisone, and most of them were also on tacrolimus, to maintain tacrolimus, so as not to stop all immunosuppression in order to have some activity against the inflammatory phase. And this shows you, this is largely before widespread use of remdesivir, and until the recovery trial was published, we had not used much dexamethasone. So tocilizumab was significantly more frequently used in our solid organ transplant population, however. And this shows you the WHO severity scale on admission, the first day of admission, and then the maximum during admission are the lower bars. And these actually were not statistically significantly different. And this shows you the daily WHO severity score throughout the admission. We are very interested in these trajectories over time. So the blue is the non-solid organ patients, and the gold is the solid organ patients. As you see, they start out at a slightly spaced severity difference, but then they really diverge after that, and the SOT improve more rapidly here. When we look at the absolute lymphocyte count, however, trajectory over time, at every point in time, the solid organ transplant patients had lower absolute lymphocyte counts than the others did. So putting this all together, we concluded that patients who've received a solid organ transplant did not necessarily experience worse outcomes than non-SOT patients within a single healthcare system. And despite having more comorbidities and being on immunosuppressive agents with discontinuation of MMF, they did not have any increased mortality, in fact, had a more rapid decrease in illness severity. And as we mentioned, we think that longitudinal of clinical courses and lab values can give you insights into the clinical features of this. And the transplant community should be aware that SOT status does not necessarily portend an adverse outcome from COVID-19. So we've actually had a lot of discussions of this with our colleagues at other centers. And there are, again, many, many possible reasons why things are different from center to center. We think that one of the things that's been very effective for us has been a really wonderful nurse and nurse practitioner-led outpatient management program for COVID. I think many centers now have this as well. They have referred over 50 patients for monoclonal antibody therapy at this point and have kept most of them out of the hospital. Our transplant center mails patients a free pulse oximeter and has close follow-up, et cetera, so that they're admitted very rapidly if they reach that point. So I think probably our SOT patients had advantage over the non-SOT in this registry because of already having the close connection with their transplant teams and the access to care. And finally, I'd like to talk about our national vaccine study in solid organ transplant recipients. I'd like to thank the principal investigator, Brian Briarski, who lent me the slides which follow, which I've modified somewhat. And particularly, I'd like to acknowledge other study team members, Jackie Garanzik-Wang, Bill Werbel, Aaron Tabayan, Alan Massey, and Dori Segev. And I really had very little to do with this study, so I'm happy to present it to you, but it's really mainly the work of this extraordinary general surgery resident, Brian Briarski, and PhD candidate. So basically what this is, it's a study now that includes between 3,000 and 4,000 patients nationally. It's a study which seeks to look at the safety and immunogenicity of COVID vaccines. by mailing in antibody testing, basically to have no in-person study visits. There's an online sign up and consent. We have Hopkins IRB approval for this, and other centers, if their IRBs require further approval, we give them documents to help with that. But really, there's been a lot of streamlining of sort of traditional clinical trials methodologies in order to try to get this done very rapidly in the setting of urgent questions in the pandemic. And so just this week, our immunogenicity data just was published in JAMA actually yesterday of the second dose, so I'll be alluding to that as well, although I couldn't put it in the slides. So basically the idea was that transplant recipients, as you know, were not included in the original clinical trials of COVID vaccines. So their responses were really largely unknown until recently. And this was, as I mentioned, an open online enrollment study. The vaccines were not supplied by the study, but if patients signed up for the study, they would get a baseline antibody level and various questionnaires. And then once they got their vaccine, the study would then ask them to send in blood from a home blood drawing device, which I'll show you in a minute, or else to go to LabCorp to have antibody testing drawn and results collected here or mailed in from the home blood draw. And so the idea was that, as you see here, this is the timetable. So there's a baseline antibody test. And again, in a 2-shot model, there would be a safety questionnaire after the first dose. And then there'd be antibody testing after the first dose, but before the second dose. And then for the second dose, there'd also be a safety questionnaire, and then antibody testing at 1, 3, 6, and 12 months after. And so as of March 16th, it's actually many more now, but there were 3,200 patients, 1,600 had received their first dose, 926 had received their second dose. And recruitment was, a lot of it was through social media. It turned out to be a highly effective way to spread the word. There were email announcements to major transplant organizations and members, and we're very grateful for the support of national, local organizations and support groups. And there were a number of patients who really took this up as a cause, as well as transplant clinicians who really vigorously advocated for this. My friend and colleague, Dr. Steve Pergam, posted these photos of himself on Twitter demonstrating the use of the home blood drawing device here, which is called a 7 Sense, and also vigorously advocated for healthcare workers who were themselves transplant recipients to be in the study. So these numbers are slightly old because now the study has more patients. The median age is 58, median years since transplant is 6, about half are kidney, about 55% female, about 10% were not white, and prior COVID diagnosis in 3%. And this shows you the reactogenicity data after 2 doses of either the Moderna or Pfizer vaccines. There was only 1 case of acute infection. And again, these are self-reported side effects. We were not testing patients for their renal function. There were no neurologic side effects reported. And basically the side effect profile generally paralleled that in the general population, meaning that the local pain and swelling and so forth was very common, as well as fatigue and headache, and then in a smaller number of patients, chills and fever. But we really did not see much in the way of unusual side effects. So immunogenicity after dose 1. So some people said, why did you publish this? It only showed a 17% antibody response after dose 1. Well, one of the main reasons to publish this was there was a lot of discussion around that time in the UK and elsewhere about potentially spreading out a short vaccine supply by just giving 1 dose of the 2-dose vaccines to each person. And we felt it was really critically important that it be made known that transplant recipients would really not benefit from being given only 1 dose of the 2-dose vaccine. And so, as mentioned, only 17% had anti-spike antibodies on either assay. So we used the Euroimmune assay for the ones that were mailed in, and then LabCorp uses the Roche Alexis, and there was really no difference in the assay used. So lower antibody responses were associated with being on an anti-metabolite, mainly mycophenolate, and a few patients on azathioprine. which are pretty common components of triple immunosuppression regimens. And lower antibody response is also associated with older age. However, interestingly, being further out in time from a transplant was associated with better antibody responses, like being 10 to 12 years out, which may signal the fact that patients who do well that long after transplant may have more well-adapted immune systems in terms of handling new pathogens or vaccines. And there was also a difference between those receiving mRNA 1273 or Moderna versus Pfizer BNT162b2 or Pfizer, as you see here. Before I go on to next steps, so we now have our dose 2 data, and I would say it's good news, but not great news. Good news because the response rate goes up to 54% overall. Bad news, or not great news, I guess I should say, because 46% of patients still don't have any evidence of antibody protection. And again, with the second dose data, mostly the associations we noted with the first dose still hold up, that with mycophenolate, there's a lower response rate. Older age is associated also with lower response rate. And there's still a little difference between the Moderna and Pfizer vaccines. I should mention there's also a parallel study in autoimmune and rheumatologic diseases being done at Hopkins by Julie Paik, Kaylin Connolly, and several others. And they're actually finding, interestingly, that autoimmune and rheumatologic patients overall have better antibody responses than our SOT patients. But within that group, it's also differentiated in terms of immunosuppression, such as those on mycophenolate or those who have received rituximab also tend to have lower responses. So what are our next steps? We really need to study potential interventions to either improve vaccine responses, or I would add to this, to find good ways of passive immunotherapy for patients who don't develop responses. So one obvious possibility is to give a booster or a third dose, but should that be the same vaccine or a different one? So we're right now poised to study that, working on the funding aspects. And then the other question is, should immunosuppression be modulated around the time of receiving a vaccine dose? But we're very careful to tell patients, don't go stopping your mycophenolate. You need to talk to your transplant team. Obviously, that risk-benefit balance is going to be different from one patient to another, and should really, those decisions should only be made in consultation with the transplant clinicians. However, it is possible that in some patients who are on stable immunosuppression, who don't have a lot of rejection, perhaps their transplant clinicians will feel it's safe to hold mycophenolate for a period of time, as we do in COVID-19 episodes themselves. So we have a lot to learn as yet. We don't know yet what the optimal intervention is, but the messaging we've been trying to convey, we had a webinar for over 700 patients. We're doing another one in a couple of weeks. We're trying to convey to them that whether they have antibodies or not, we don't know, first of all, how protective these are for them, but everybody should maintain all of the safety measures, masking, hand hygiene, social distancing, everything that's protected them so far, because we can't assume for our transplant population that being vaccinated is protective as it is for the general population. As long as there's transmission in the community, until we know more, we want to make sure that they continue these safety measures. And again, getting back to the principles of Bob Rubin that we started with at the beginning of the talk. So it turns out the net state of immunosuppression, as reflected in these differential immunosuppressive regimens, does seem to make a difference in vaccine responses here, although initially the concept was coined in order to explain infection risk, it may also explain antibody responses. And again, the idea being that we must go to the limit, we must have sleepless nights and put all of our effort into protecting the most vulnerable patients. So the other side of the coin, I didn't talk too much about monoclonal antibodies today, but we're very excited about that. As mentioned, we have a nurse practitioner-led program that's referred 50 patients so far for outpatient monoclonals with very good results. We also have a group of severely B-cell depleted patients with chronic lymphocytic leukemia, lymphoma, myeloma, or other such entities who also don't mount antibody responses. And so for those patients, we have had several that had COVID active for over 2.5 months with low cycle thresholds, really detecting active infection. And for 4 of them, we've been able to clear them with emergency IND, casirivimab and devimab monoclonal antibody, plus off-label remdesivir. I'm just mentioning that to say that that's not necessarily the only way to do this, but I think we're going to need a lot of creative approaches which combine passive immunotherapy with active antiviral therapy for treating or preventing COVID in our most vulnerable patients. So to conclude for the whole talk, there is a spectrum of infection risk among transplant recipients. They're not all created equal, or even at different times, they may have different risk profiles. And despite prophylaxis and treatment and vaccinations, some of them remain highly vulnerable to infections, including CMV, including COVID-19 and all the other infections we talked about. The net state of immunosuppression is a major factor, and we need more attention to strategies to protect our most vulnerable patients. And I commend you all for, first of all, your great clinical care, and for the fact that you are the future. You are going to surpass us in every way, teach us what our mistakes are, and find better ways to take care of these patients. I'd like to thank my colleagues in the Epidemiology Research Group, led by Dori Segev, and our Johns Hopkins Department of Medicine and Division of Infectious Disease with Dave Thomas as the chair, Paul Auwerter as the clinical chair, and Kieran Marr as our Transplant Oncology ID Director. I am really fortunate to have wonderful colleagues. And thanks to all of you, Dr. Chimpone, Dr. Kumar, to the Planning Committee and the Georgetown Department of Medicine, Division of Infectious Disease and Tropical Medicine. And thanks to all of you who are listening, and I wish you all the best. Thank you for having me today.
Thank you so much, Dr. Avery. That was just an amazing talk. I really, really thank you for it.